Okay, hi everybody. Welcome to Pediatric Grand Rounds. Today is one of our Frontiers in Child Health Research seminars. And I'm very pleased to introduce our speaker, Dr. Steven DuBois, who is a professor at Harvard Medical School and director of the Experimental Therapeutics at the Dana-Farber Cancer Institute. Dr. DuBois is actually an alumnus from our program here at UCSF. He originally did some of his neuroblastoma research training here under the mentorship of Dr. Matthay. And so it's really great to have him back now, sharing what he's been working on in the ensuing years. Today, he'll be discussing his work related to closing the survival gap in high-risk neuroblastoma. So please welcome Dr. DuBois.
Thanks so much. It's great to be back and to see so many familiar faces and to share some of the work that in many ways started here and has continued after I've left. So these are my disclosures, none particularly relevant to today's presentation. So for the residents in the audience, important just to level set a little bit of background about neuroblastoma. So this is our most common pediatric non-CNS solid tumor. Despite neuro in the name, this is a peripheral nervous system tumor that can arise most commonly in the adrenal gland, although anywhere along the sympathetic chain, as shown in the figure on the right. This is a disease of young children, which is a challenge for someone like me who is a drug developer, but we persevere. So 60% of children are diagnosed before the age of 2, and 97% are diagnosed before the age of 10. I think neuroblastoma has had kind of an outsized interest in the research community because there's such a tremendous heterogeneous behavior, all the way from tumors that can spontaneously mature, so-called stage MS disease, to really the focus of today's talk, which is high-risk neuroblastoma, typically defined as metastatic disease in patients over 18 months of age or children with MYC amplified neuroblastoma. And so for those children with high-risk neuroblastoma, we have seen some steady improvements in event-free survival by treatment era. So these are some data I helped to generate from the Children's Oncology group. And you can see for newly diagnosed high-risk neuroblastoma, when I started medical school, would have been right around here, and started working with Kate Matthay. So really terrible outcomes. And then through the work of cooperative group clinical trials and a number of advances, we've gotten to about 50% at this point. So clearly still a lot of work to do for newly diagnosed high-risk neuroblastoma. The outlook is much more grim for children with recurrent high-risk neuroblastoma. And so some data from the UK are shown in the Kaplan-Meier curve on the right. And you can see that the vast majority of these children, well, this is an overall survival curve. The vast majority of these children will not survive their disease. And maybe there's a glimmer of hope after the year 2000, ever so slightly more favorable, but still absolutely terrible survival rates. So I've been interested in neuroblastoma for decades now, and in particular, interested in its radiosensitivity. And so there's a number of preclinical and clinical data that really point to the tremendous radiosensitivity of this disease. So the preclinical data are shown on the right. This is an assay that assesses the degree of radiosensitivity across a panel of adult and pediatric cancer cell lines. And you can see actually my two favorite diseases are all the way to the right, neuroblastoma and Ewing sarcoma. Maybe I should say they're my least favorite diseases because I'm trying to get rid of them. But they're all the way over to the right among the most sensitive cancer cell lines in this screen. Clinically, we know this as well. When we treat patients with high-risk neuroblastoma, we use external beam radiation to their primary tumor bed. And the dose that we use is really quite modest. And I was able to participate in a children's oncology group analysis looking at a typical oncology question. If some radiation is good, more must be better. So we asked that question using historical controls from the A3973 clinical trial, where children received standard dose radiation, and then the ANBL 0532 clinical trial, where children received a boost dose of radiation, so a higher dose. And you can see adding more radiation actually does not improve outcomes in this disease, highlighting that you just need a little bit of radiation in this very radiosensitive tumor. The challenge, though, with high-risk neuroblastoma is the tremendous burden of metastatic disease that these children face at initial diagnosis. And so actually one of our radiation oncology students, when I was here at UCSF, cataloged the number of metastatic lesions at initial diagnosis, and he found that the median was 12 metastatic sites at initial presentation. For the pediatric oncologist in the room, that's not a surprise. You can see the scans with just innumerable sites of disease. But from a therapeutic standpoint, that's a problem because it's not feasible to consolidate or treat all of those sites with conventional external beam radiation, and really would require what we call TBI, total body irradiation, which has tremendous late effects and is not something that we're interested in resuming. We did that decades ago, and that has appropriately fallen out of favor. So this is where the idea of radiopharmaceuticals comes in. If you can't consolidate all of these sites with conventional external beam radiation, can we use a radio-labeled drug to target all of those sites? And so that's really going to be the focus of my talk today. So there are at least 4 cell surface targets that have been considered for radiopharmaceutical therapy in neuroblastoma. Far and away the most common, and what most of my talk will be about, is targeting the norepinephrine transporter, or NET, that's overexpressed in more than 90% of neuroblastomas. But I'll touch on a few of the other targets. So somatostatin receptor 2, there's some interest in that, largely piggybacking off of adult clinical development for adult neuroendocrine tumors. GD2, we know, is a well-validated target in neuroblastoma. We use a monoclonal antibody to treat these patients routinely, but there are now some radiopharmaceutical strategies. And then I won't talk more about B7H3, but there is a long history of targeting B7H3 with a radioisotope as well. And so really the idea here is that if you have a radio label and a targeting moiety, you can determine in real time whether your patient is a candidate for that radiopharmaceutical. And so this is what's called a theranostics approach, or a molecular radiotherapy approach. So this happens to be an MIBG scan, but could be a B7H3 scan or a GD2 scan. We actually don't have those, so it's an MIBG scan. And so this would be a candidate for treatment with high-dose MIBG therapy based on their diagnostic scan. Whereas this patient, where the only sites of uptake are in normal tissue where we expect MIBG uptake, that patient wouldn't be a candidate for MIBG therapy, but might be a candidate for a different form of molecular radiotherapy if their tumor expressed that target. And so my goal is to share with you a little bit of the past, present, and future of our thinking about radiopharmaceuticals for children with neuroblastoma. And really the OG, so to speak, is I-131 MIBG, which in many ways was developed here at UCSF by Kate Matthay. This was one of the first centers to offer this treatment all the way back in the 80s for children with relapsed high-risk neuroblastoma. And so I'll take you through a little bit about how MIBG works, because that will be important to understand some of the later thinking about combination strategies. So the drug's given intravenously, circulates through the bloodstream, and is taken up selectively by cells that overexpress the norepinephrine transporter. Once it's taken up by those cells, we think it's locked in the cells by something called VMAT2, and then the isotope undergoes beta decay with a half-life of 8 days, while during which it's continually radiating the tumor cells, which of course leads to DNA damage. And if that DNA damage is sufficient, it will be overwhelming to the cell, which will then undergo apoptosis, which makes us very happy as oncologists. So we've known now for decades that MIBG is one of the most active single agents available for the treatment of high-risk neuroblastoma. So in a large phase 2 study, we're back. Large phase 2 study led by Kate Matthay. This was a multi-center study. She reported a 36% response rate for children with relapsed or refractory disease. And there's been a systematic review done by our UK colleagues that showed a mean response rate of 32% if you pool all single agent trials. There's been some look at who's most likely to benefit from this approach. So this is from that large phase 2 study, and it seems as though the main predictors were older age with an odds ratio of response of 3.8, having maybe more limited disease versus more widespread disease, fewer lines of therapy. That's a general principle in oncology, and longer time from diagnosis to first treatment with MIBG, another kind of general principle in oncology. So these are all very clinical predictors, and we've been working on some newer predictors that I'll share with you later in the talk. Colleagues in the Netherlands, because of frankly, the small size of their country, they've been able to centralize care for children with neuroblastoma and have run protocols where MIBG therapy is the very first treatment that a child with high-risk neuroblastoma receives. So this is one of their former treatment schemas, where the patients would receive two blocks of MIBG therapy and then start chemotherapy, which provides an opportunity to understand in an untreated patient population what's the probability of response. And so in this one report, they reported a 38% response rate, although a number of patients had early progressive disease as well, kind of highlighting the fact that we need to understand more about who's likely to do well with this modality and who's not likely to do well with this modality. So some of these data help to inform some of our thinking in our National Children's Oncology Group about how we might integrate MIBG therapy into frontline care. There's been some early experience with a drug called dotatate, which targets the somatostatin receptor and uses a lutetium-177 radioisotope. And you're not meant to read the abstract, but you are meant to read this part that I've blown up that says none of the 14 evaluable patients had an objective response rate, which was certainly a disappointing finding. We think part of that might be because that this was relatively low dose and the treatments were given kind of far apart. And basically this trial borrowed the dosing strategy that's used for adult neuroendocrine tumors, which are totally different diseases. And we understand that the clinical behavior of neuroblastoma is much more aggressive. And so giving a low dose spaced at a wide interval is not the way to treat high-risk neuroblastoma. So there's now work looking at higher dose and more compressed dosing of this agent in an ongoing trial in Europe. So that's a little bit about the past, and I'll tell you in this section of the talk about some of the work that we've been doing looking at MIBG combinations and how we've thought about moving MIBG into the frontline setting, not in the Netherlands, but in a much larger country like the United States. So I would say, currently we're in this era of MIBG combination therapies, and as is another common theme in oncology, combination therapy generally is favored over single agents, with a goal of improving upon the known activity of each of the agents. And in thinking about ideal drugs that might partner with MIBG, an ideal drug would sensitize neuroblastoma cells to radiation, itself have some activity against neuroblastoma, have non-overlapping toxicity with MIBG, which is generally hematologic toxicity. We've kind of figured out over the years how to mitigate that by giving a boost, an aliquot of peripheral blood stem cells. And then, of course, not already be used in upfront therapy for children with high-risk disease, with some worry about cross-resistance if they've already had a drug. So there's a few different levers that we can pull in thinking about this mechanism of action. We could think about ways to increase norepinephrine transporter, thereby increasing the uptake of MIBG into the neuroblastoma cells. In terms of the isotope itself, we can think about either using a different isotope, or what I think we might need in this field is combining different isotopes that have different path lengths, so you can get some tumor cells right near where the isotope is and some larger clusters of cells. We can think about co-administering a DNA damaging agent to try to further push cells to a state where they have overwhelming DNA damage and are tipped into apoptosis. We can think about impairing the DNA repair machinery with the same goal. And then we understand that tumor cells seem to be more sensitive when they're in the G2M phase. And so we could think about recruiting tumor cells to the G2M phase and then coming in with radiation exposure. So I'll take you through a few vignettes of what's been done with each of these approaches. So in terms of combining with a DNA damaging agent, some colleagues in Scotland focused on topotecan, a camptothecin, that in their preclinical work showed strong reduction in tumor volume. So this is a somewhat complicated experiment, but the bottom curves here, which show reduced tumor volume, are those that included topotecan alongside MIBG therapy. Those data were translated into a clinical trial that showed some activity, so a 9.5% complete response rate, 9.5% partial response rate, not a home run. And concerningly to us in North America, a very high rate of hematologic toxicity. That's because topotecan has as its main toxicity hematologic toxicity. MIBG, I've already told you, has hematologic toxicity as its main adverse event. And furthermore, in North America, we already use topotecan as kind of a cornerstone of our initial frontline therapy. And so we became interested in the combination of MIBG with a different camptothecin, irinotecan, which has much less hematologic toxicity. And so working together with the NANT consortium, a consortium of North American institutions focused on relapsed neuroblastoma, we ran this phase 1 trial. And so this was a dose escalation trial where we kept constant the dose of vincristine and irinotecan and escalated the dose of MIBG to our usual maximum dose of 18 millicuries per kilogram. And we showed that this was a tolerable approach, and we showed a 25% objective response rate. I put the UCSF logo here because while that trial was ongoing, there were a couple of laboratories here that became very interested in a class of drugs called histone deacetylase inhibitors, or HDAC inhibitors, in particular a drug called vorinostat that was FDA approved for cutaneous T-cell lymphoma. And so there was a pharmacology lab that somewhat serendipitously was interested in modulators of norepinephrine transporters, and as part of a screen identified that vorinostat showed dose-dependent increases in norepinephrine transporter transcript, and in data I'm not showing protein expression. So those data are shown here in the upper left. Daphne Hoskogan, in parallel, became interested in HDAC inhibitors as radiation sensitizers, and so she was able to show that vorinostat on its own led to increases in gamma H2AX, a marker of DNA damage, and that was augmented when combined with external beam radiotherapy. So Sabina Mueller, who's known to many in the audience, ran this preclinical experiment, which showed that adding vorinostat to external beam radiation in neuroblastoma preclinical model led to reduction in tumor volume. And so we were able to translate those preclinical findings into a phase 1 trial in the NANT consortium. Again, a dose escalation study. This time, though, we were sort of escalating kind of stepwise, a little bit more vorinostat, a little bit more MIBG, and so on. We were able to show increases in histone acetylation as a pharmacodynamic marker in patients treated with vorinostat using peripheral blood as a surrogate marker. And then we showed a relatively modest response rate in this dose escalation trial, but a number of responses if you just look at their at patients' response by MIBG scan, and in particular at the higher dose levels of this phase 1 dose escalation trial. So at the completion of this trial, we were left with data for single agent MIBG, data for irinotecan with MIBG, and then data for treatment with MIBG and vorinostat. And we didn't know if we were just causing side effects or if we were improving outcomes for these children. And so that led to this R01 funded trial, again conducted through the NANT consortium. This was the first randomized trial that the NANT conducted, and it was a 3-arm trial where children with relapsed or refractory neuroblastoma were enrolled and randomized to those 3 arms. Arm A with MIBG monotherapy, Arm B with MIBG, vincristine, and irinotecan, and Arm C with MIBG and vorinostat. And importantly, all of our phase 1 work had arrived at the same dose of MIBG, so that was not having different doses between the arms would have certainly been a confounder. So all patients received the same dose of MIBG, 18 millicuries per kilogram, and they all received autologous peripheral blood stem cell support to sort of kind of level the playing field in terms of hematologic toxicity. The primary endpoint of the trial was response after 1 course using the NANT response criteria. Response evaluation in neuroblastoma is kind of niche, so I'm not going to go more into the details of that, and you can thank me later. We used a modified intent to treat analysis where all eligible patients who received a dose of MIBG were included. And our sample size required 105 patients to allow 80% power to select a winner, assuming the winning arm had a response rate that was at least 15% higher than the other arm. And then there were 2 interim analyses along the way with the potential to drop a losing arm or to declare an early winner. So patients were eligible for this trial if they were 1 to 30 years of age and had relapsed refractory or persistent high-risk neuroblastoma. Following the theranostics principle that I showed earlier in the presentation, everyone had to have at least 1 MIBG avid site of disease, right? We don't think MIBG is an appropriate therapy if you don't have avid uptake of the tracer. Because everyone received peripheral blood stem cells, they had to have adequate banked stem cells and adequate organ function. And then we allowed prior MIBG if enough time had passed. So this is the consort diagram from the trial. We ended up enrolling and randomizing 114 patients. You can see after excluding patients who were either found post hoc to be ineligible or patients who didn't receive MIBG therapy, we ended up with 36 patients in Arm A, 35 patients in arm B, and 34 patients in arm C. You might ask, well, why would patients not receive MIBG therapy? This is a very different type of drug, right? This is not something just stored in the pharmacy, ready to take off the shelf and give to a patient when ready. It's made for each patient, right? Because once you make it, the decay, the radiation decay starts. And so this is what Kua and Fabi deal with every week. And production issues and things like that. So it's really kind of bespoke medicine. It's made for the individual patient. So these are the characteristics of the 105 eligible and evaluable patients per our modified intent to treat, and they're fairly standard expected characteristics for a relapse refractory high-risk neuroblastoma patient population. So median age of about 6 years, a relative paucity of MICAN amplification. That's because in general, those patients with relapsed MICAN amplified disease tend to progress fairly quickly, and they end up sometimes not being candidates for MIBG therapy. We use something called a Curie score, which quantifies the burden of disease based on the I-123 diagnostic MIBG scan. And so that score goes from 0 to 30. And so you can see the median Curie score was 7 to 8 across the arms, pretty well balanced. And so this was a trial that took many years to develop and complete and fund, and it all boils down to a single slide. But it's a good slide. So this was our primary endpoint response after the first cycle, and you can see 14% for arm A, 14% for arm B, and 32% for patients randomized to arm C with vorinostat. And so that was declared the winning arm. Some of you might be wondering about this 14% response rate, since I showed you on the earlier slides that the historical data would have suggested a response rate somewhere in the 30% range. And I think important to understand that some of those older studies maybe use different response criteria, did not have central review of response. And so if a patient's scan maybe looked a bit better, they may have been coded as a responder. But under sort of standardized agreed upon response criteria with central review, these are the results that we obtained. Since all patients on the trial had MIBG avid disease, we could use that Curie score and plot what we call the relative Curie score, the change in Curie score, to make these waterfall plots that we like to see in oncology, where things below the 0 line mean things are getting better, things above the line mean things are getting worse, and things at the line have stayed the same. And so you can see for those same 3 arms of the trial, that arm C, again, if you just look at the response by MIBG Curie score, again, was arm C with vorinostat was superior. We've tried to understand, well, why are we seeing this? Why are we seeing this effect? And so we've used, again, peripheral blood as a surrogate marker to understand some of this biology. And so we used ELISA to look at FLT3 ligand as a marker of hematologic toxicity, and interestingly saw that the children randomized to the vorinostat arm had lower FLT3 ligand, suggesting that perhaps vorinostat may play a role protecting normal tissues from the effects of radiation therapy. There's actually a whole body of literature about this in adult cancers, where HDAC inhibition appears to sensitize tumor cells, but be somewhat protective to normal tissues, which is kind of interesting. And then we looked at CDKN1A over time in the peripheral blood, and saw lower levels in the vorinostat arm compared to arm A with MIBG alone. And that to us, because this is a marker of cell cycle arrest, suggests that perhaps the vorinostat is impeding the usual mechanisms that would allow for DNA damage repair to take place, and then pushing that cell into apoptosis. And then, in addition to looking at individual proteins like FLT3 ligand and looking at individual transcripts like CDK N1A, we also did a whole blood RNA-seq looking at broader transcriptomic changes. And so I show the Venn diagram here that shows genes in the peripheral blood, largely we think lymphocytes, that were upregulated and genes that were downregulated following protocol therapy, and divided that by randomized arm. And what's really striking to me is how little overlap there is between these arms, both in terms of the upregulated genes and the downregulated genes. And how much these radiation sensitizers are really driving differences in gene expression. Again, in a surrogate tissue, not in the tumor. So the other combination we've been very interested in is the combination of MIBG together with a GD2 antibody, which again plays a pivotal role in the care of children with high-risk neuroblastoma. And so there's some data, preclinical data, looking at external beam radiation alongside a GD2-directed antibody in neuroblastoma preclinical models, and you can see really nice reduction in tumor volume in work done from University of Wisconsin. In parallel, some data from Europe indicated that vorinostat, in addition to increasing norepinephrine transporter expression, also upregulates GD2 expression. And in this preclinical study, evaluated not a radiation combination, but the combination of vorinostat and a GD2 antibody, and showed that that combination was superior to the other control arms on that preclinical study. So all of that work was kind of coming out just as the results of our NANT 1101 randomized trial came out, indicating a role potentially of vorinostat. And so Thomas Cash at Emory led the NANT 1701 phase 1 trial. It was primarily focused on MIBG and dinutuximab, a GD2 antibody, to evaluate the feasibility and activity of that combination. But as these results were coming out from our randomized trial, we said we've got to add an arm where we look at the 3-drug combination with vorinostat. So that trial's now been completed and has a really encouraging response rate. So it's the same waterfall plot looking at change in Curie score from baseline. So part A is the 2-drug combination, where the response rate was 42%. And then if you factor in something called minor response, it's 46%. If you look at part B with the 3-drug regimen, you can see a response rate still 42%, but if you look at some of those minor responses, generally improvement by MIBG scan, all the way up to 75%, and there were no patients who had disease progression on that arm of the trial. Relatively small in the context of a phase 1 study, but certainly interesting. So I'll transition here to thinking a little bit about frontline therapy. A lot of what I've just talked about has been for children with relapsed and refractory disease, but obviously our best chance for curing a kid with high-risk neuroblastoma is at initial diagnosis. And so I was involved with the Children's Oncology Group analysis, where we looked at probability of event-free survival according to your response at end of induction therapy, which currently is standard chemotherapy and surgery. And so what we showed in this analysis is that children who have a partial response compared to less than a partial response have a much better event-free survival, and that effect is magnified if you look at patients who have a complete response in the dashed line compared to patients with less than a complete response in the solid black line here. And so this suggests to us, some of this is obviously just related to tumor biology. It's better if you've got chemo-responsive disease, but it also suggested to us that if we can be more aggressive with inducing a better response up front with better induction therapy, that maybe will improve outcomes for more kids. So Dr. Mueller is here, and I've already shown the slide that shows her work. No, it's all good. I think the other important observation that motivated moving MIBG into the front line here in North America is that high-risk neuroblastoma has a propensity to relapse in prior sites of disease that were already present at initial diagnosis. So this is that same industrious rad-onc student at the time who cataloged sites at diagnosis and then at first relapse. And so this is that Venn diagram. So the 394 are all of the sites at initial diagnosis. This circle is all of the sites at first relapse. And you can see they're almost complete overlap, highlighting again the importance of trying to consolidate the sites that we know are present and are likely to recur if we don't consolidate those sites. The issue all along, though, has been that MIBG can only be administered at specialized centers. It requires a specialized nuclear medicine team, specialized room. We've got a lead line room. I shouldn't say we. I used to work here. I don't work here. You have an MIBG room, lead lined room upstairs, a dedicated facility, and a team, right? Kua and Fabi really, and the research coordinators all know how to do this and do this well. So in 2011, this was the landscape, and we were really worried about doing a large randomized phase 3 trial in high-risk neuroblastoma and having lots of patients have to travel really far from home, right? Like look at Southern California, tons of kids in Southern California, no site. Look at Texas, tons of kids, one center. Look at Florida, tons of kids, no center. So we were pretty worried about this, and there was a big push over the ensuing years to open a lot more MIBG programs. Still none in Florida in 2018. Still none in 2026, but that's fine. And even a couple opened in Canada, which is important for us because our children's oncology group clinical trials include U.S. and Canada. So we felt like by 2018 that we had enough bandwidth nationally and in Canada to get this done. And so I had the privilege to chair this phase 3 clinical trial sponsored by the Children's Oncology Group for children with newly diagnosed high-risk neuroblastoma. It's a little bit complicated, so I'll take you through. So children on this trial, ANBL 1531, enrolled, had central assessment of their MIBG avidity, again, understanding that MIBG therapy would not be relevant for a child with MIBG non-avid disease. And then we centrally assessed their ALK status. And so for children who had MIBG non-avid disease, they were non-randomly assigned to just get COG standard therapy. And then for children who had an ALK aberration, this is still an ongoing experiment, they were non-randomly assigned to receive COG standard therapy plus the ALK inhibitor lorlatinib. And so that's still recruiting. But the bulk of the trial, the randomized portion of the trial, was centered around this MIBG question. So I apologize, there are different arms A, B, and C than what I already told you about, but bear with me. So arm A on this trial was basically COG standard therapy. That's the comparator arm. Arm B was exactly the same, except patients received a block of MIBG therapy during induction and then continued on to receive all of the same therapy. So this is the most pure experiment in the trial, arm A versus arm B. Around the time we were designing this trial, there was a lot of interest particularly in Europe, of using a different type of transplant than our COG standard transplant, using busulfan and melphalan, or BuMel. And so arm C used MIBG during induction and that BuMel transplant versus our more toxic standard COG induction. So if you look at the randomized portion of the trial, you can see here arm A, there's the topotecan that I talked about earlier. Patients receive stem cell harvest, additional multi-agent chemotherapy, surgical resection of their primary site, more chemotherapy, and then end of induction. Patients on arm B received MIBG after the third cycle, as did patients on arm C. We didn't use the full dose of 18 millicuries per kilogram in this trial because we were worried about having long gaps in therapy. We know that the hematologic toxicity with this agent can take weeks to recover, and so we were worried about pushing the dose. So we used a compromised dose of 15 millicuries per kilogram, and all patients received an aliquot of their peripheral blood stem cells so they could more quickly move on to the next phase in their therapy to avoid long gaps. So patients were randomized in a ratio of 1 to 1 to 0.5, really prioritizing the main experiment of arm A versus arm B. We had 81% power with a one-sided alpha of 0.022 to detect a hazard ratio of 0.63 in favor of arm B compared to arm A. And so if you do the math, which I didn't have to do, it yielded a sample size of 500 randomized patients. But as with all large phase 3 trials, there's always the potential for arm dropping. And indeed, that happened. Arm C dropped early after the first 50 patients were randomized to that arm. And so the remaining patients were randomized to arm A versus arm B. And so this was, well, this is a bit of a cliffhanger. I don't have the results. You'll have to invite me back after October. But this was a success in the sense that we were able to accrue and move patients around to get them treatment if they were randomized to an MIBG containing arm. And so we've enrolled 706 patients and randomized 503 patients, which is a real testament to the cooperative group in the cooperative group mechanism. So we closed to accrual in September of 2023, and per the design of the study, we have to wait 3 years from end of accrual to access those data. So we expect that the Data Safety Monitoring Committee will release those data in October, and we'll have our answer. I've already started writing the paper. Don't know what it will say, but I've already started writing the paper. So I'm calling that the past. Some of it might be the future, but I do want to talk about what we're trying to do to continue to innovate for these kids, because honestly, one of the conclusions of this talk should be that we probably shouldn't be using a drug from the 1980s to treat high-risk neuroblastoma in 2026, right? There's probably something that we can do that's better. And so some of this stuff, I think, may be things that may further improve outcomes for this population. So I'll just take you through a few of these. So I mentioned GD2 as a validated target in high-risk neuroblastoma. And so there's some work now using this technology called a SADA, self-assembling, disassembling moiety, as a novel radiopharmaceutical. And so the liability here, if you just use an antibody tagged with a radioisotope, is that there'll be a ton of blood exposure that will lead to a lot of off-tumor toxicity. And so there's a number of approaches that one could use that allow you to first tag the tumor and then come in subsequently with the radioisotope. And so that's this SADA strategy that targets GD2. And so I just show you some of the preclinical data here. If you look just at this, just at the radioisotope itself, you can see very little activity in this neuroblastoma preclinical model. Whereas if you pre-target with the SADA moiety, you see really beautiful tumor response and, not surprisingly, really beautiful progression-free survival. So we've become very interested in this as a potential novel radiopharmaceutical to potentially bring into the NANT consortium. So there's an ongoing trial in adults, and the hope is at some point that we would be able to bring this into neuroblastoma. It's complicated slightly by the fact that this company's now been acquired by a much larger company, and it's not clear to what extent this will continue, but we await that determination. The other strategy that has been very active in medical oncology is the use of alpha particles. So these have short path length, high energy emissions that seem to be more effective at generating DNA damage. And again, the whole principle here is to generate overwhelming DNA damage, tip the cell into apoptosis. And so some work from CHOP has started to look not at MIBG, which has iodine 131, but instead to use an alpha particle called astatine, or MABG. And so you can see here in these two preclinical experiments, here's the MIBG, which is currently the gold standard. And you can see very nice activity. You can see some activity of the MABG, but not to the same extent. So despite these data, CHOP is moving forward with a trial together with Princess Maxima in the Netherlands of a first-in-child study of MABG, which I think will be the first alpha particle trial for children with any diagnosis. There's another alpha particle with lead, which I know for pediatricians is a hard sell, and maybe for parents, but it's a very tiny dose of lead, non-toxic dose of lead, which is another alpha particle. And so this targets the somatostatin receptor. This drug, even though it's called AlphaNet, it targets the somatostatin receptor and has entered adult phase 1 testing. And you can see in that population some level of activity. And so we've started to have some conversations with this company about whether there might be a role for this type of alpha particle for neuroblastoma. And then your very own Q of O is chairing an upcoming NANT randomized trial, which again will have different arm A, B, and C nomenclature. But the goal here is to build upon the experience of the NANT 1701 trial evaluating MIBG plus dinutuximab, or MIBG, dinutuximab, and vorinostat. So patients will be randomized to arm A, MIBG, and vorinostat. Arm B, the two-drug combination of MIBG and dinutuximab, and Arm C, MIBG, dinutuximab, and vorinostat. So, God willing, this trial will open in 2026. And importantly, has no monotherapy, right? So we're really continuing on with combination strategies to try to maximize benefit for our patients. There's a trial that's in development in the UK and Toronto that will evaluate the combination of MIBG plus a PARP inhibitor. This relies on this idea of impairing the DNA damage repair machinery to try to increase DNA damage. And so there's some nice data from an investigator, Sally George, in the UK, who has shown that if you add either rucaparib or olaparib to radiation, you can see a reduction in surviving fraction and increases in gamma H2AX as a marker of double-strand DNA break. So this trial won't be a NANT clinical trial, just be those two institutions, and I hope will open as well later this year. And then Purna Kumar, when she was a fellow here at UCSF, worked with Young-Ho Seo, looking at alisertib, an Aurora A kinase inhibitor, with a goal of recruiting cells to the G2M phase when they would be expected to be more radiosensitive. And so in the figure on the top, she shows that indeed she was able to get these cells with alisertib to the G2M phase, and then showed increases in gamma H2AX in two different neuroblastoma cell lines. And then a combination of MIBG along with alisertib showed really flat tumor growth here in this blue curve. And then I think we need to do a better job of patient selection, right? Our current biomarkers are the scans, right? We need to see that the patients have MIBG avid disease, and then some clinical hints from treating patients for many years that older patients maybe do better, and fewer lines of therapy and all of those data that I showed earlier. So we've done some additional biomarker work trying to understand whether we can better select patients for MIBG therapy. And so we collaborated with UCSF on an evaluation looking at tumor norepinephrine transporter, and which mediates uptake, and VMAT2, which mediates retention of MIBG in the tumor cells. And we went into this with a very strong hypothesis that higher levels of either of those would be associated with a higher probability of response. And we were totally wrong. It ended up being the opposite. And so this has now led us to think that maybe there's something about cell state that some of these markers are telling us about, but that you don't necessarily need to have sky high norepinephrine transporter to respond to MIBG therapy. And then, of course, it's 2026, so we've become very interested in circulating tumor DNA as a potential early response marker in this disease. So these are data from the NANT 1101 randomized trial that I told you about, where you can see serial samples over time looking at percent ctDNA in patients who didn't respond to that protocol therapy, where the circulating tumor DNA remains detectable at day 15, and then of course at day 50 in a subset of those patients. Whereas in patients who responded by day 15, they were all clear and remained clear at day 50, which I think is intriguing to us, needs validation, but is also maybe a strength in a disease where response assessment is so complicated. And then, of course, in the context of a randomized phase 3 trial with 500 patients randomized, we have a major biomarker effort ongoing where we're looking at somatic markers, immune markers, germline markers, and then, of course, serial blood-based markers to try to understand, even if AMBL 1531 is a null finding where the outcomes are similar whether you receive MIBG or not, it will be super important to understand whether there's subpopulations who may yet be identified who could still benefit from that approach. And so one of the serial blood-based markers that we're interested in is, of course, ctDNA. So these are some initial data from Brian Crompton's lab at Dana-Farber, where we've looked at, I think now, over 2,000 samples from this trial. And you can see a few things. First, the tremendous burden of circulating tumor DNA at baseline in children with newly diagnosed high-risk neuroblastoma. This is the highest burden of disease, highest burden of circulating tumor DNA in any cancer, adult or pediatric, that's been looked at. So very interesting. You can see as well the chemosensitivity of the disease. After just one cycle, you can see a strong decrease, though a wide range, in circulating tumor DNA. And then you can see a subset of patients who have a ctDNA relapse. We're blinded to whether there are clinical relapses, but Brian has a sense that these patients likely have relapsed because we are seeing ctDNA that has gone down and then has come back up. So in October, when our data are unlocked, our clinical data are unlocked, this will be really fascinating to look at. And then these are of course, Brian remains blinded to treatment arm. So this is for the whole trial in aggregate, whether they received MIBG therapy or not. So that's obviously, of course, going to be of intense interest post-October. And then I showed you earlier data about the RNA sequencing changes after MIBG therapy. That was using a surrogate marker in peripheral blood. But now, in the context of AMBL 1531, we've kind of a natural experiment of tumor material from initial diagnosis and then second look surgical samples that were all obtained after patients received MIBG therapy if they were on arm B of the trial. And so you can see here a volcano plot that shows up and down regulated genes for arm A, which really reflects chemotherapy, and arm B, which reflects chemotherapy and radiation therapy. And what's really fascinating here are the differential expression changes. So you can see that of the differentially upregulated genes, that 251 were shared between arms A and B, 136 were unique to arm A, and 515 were unique to arm B. So the postdoc in Elaine Martis's lab, who's kind of diving into this, really trying to understand, well, what pathways are uniquely different in these radiation treated patients. So I hope that I have given you an update on the past, where we have had a heavy reliance on MIBG monotherapy, a focus largely on a relapsed refractory population, very little evaluation of novel radiopharmaceuticals, and patient selection almost exclusively via theranostics, looking at the scan. A little bit about the present, where we're in the age, thankfully, of combination trials. Randomized combination testing, and then frontline randomized testing, and then the future of GD2 as a theranostics target, novel isotopes, novel MIBG combinations, and then being smarter about leveraging novel biomarkers to try to optimize patient selection. So with that, I'll acknowledge first and foremost the patients and families who have the courage to participate in our clinical trials and our clinical research. Collaborators, I put Kate appropriately in bold and large font here, because this is all because of Kate, right? Everything I've learned is because of Kate, and she has really led the charge here. My trainees, industry partners, Megan Granger at St. Jude helped the NANT 1101 co-chair the NANT 1101 trial, and then this is our AMBL 1531 team on a canal boat in Amsterdam, so that's pretty fun. And then funding sources. Thanks so much. Happy to take questions.
I have a biomarkers question for you. The peripheral blood biomarkers that you showed, you raised the point that it was interesting that the vorinostat and the irinotecan had like really high signal. I think on one hand that's interesting. On the other hand, those two drugs are systemically sort of circulating and absorbed as opposed to the MIBG. Do you think there's going to be any way to sort of try and interpolate that data back onto the 1531 data? And in other words, ask, like, does vorinostat provoke a signature that is seen in responders?
Yeah. Well, it's a great question, Amit. I'll answer it in two ways. One, the postdoc who's working on the AMBL 1531 work, I have referred him back to that Campbell paper and said, even though there's no vorinostat in AMBL 1531, I think there's a lot that he can learn and try to understand from what he's seeing, not in a surrogate tissue, but in the real tissue. And then on Kia's trial, she has an R01 looking at biomarkers within that trial, and we'll include as part of that looking again at a surrogate marker in the peripheral blood and try to understand in the context of a different 3-arm trial what we can learn. Alejandro.
Fantastic talk, Steve. Sort of follow up from Amit's question. Has anybody done, speaking of sort of the future sensitizer screens, CRISPR sensitizer screens, looking at MIBG plus vorinostat to see what genes sensitize the response? I think, what's I think missing from a lot of what we're doing is sort of feeding back to basic science.
Yeah.
Trying to understand what are the mechanisms here.
Yeah, no, and that's why we wanted to look at, we wanted to make that a biomarker rich study to try to understand. To my knowledge, no one has done that type of experiment. So it's certainly something that might be worth doing, and also looking at other potential radiation sensitizers that may originate from that type of work. I will say in the work that Sabina Mueller did in Daphne Hoss-Kogan's lab, they did identify changes in maybe it's KU67. I might be totally making up the name of that gene, but it was a gene that was modulated with vorinostat in a low throughput type of way that was thought to be part of the explanation for the radiation sensitization, but not, that was done, more than a decade ago now, and not the type of kind of, 2026 and, NGS type screen that we can do. Yeah, Bo.
Steve, thanks for the talk. I was curious, with the data you're gathering on responders versus non-responders for precision medicine and deciding like who just shouldn't ever bother to get MIBG. So obviously besides a negative scan, like how close are you to having, whether it's molecular features in the diagnosis or other things to tell you steer a family away from like a therapy that has promise but is a burden?
We're far away, I would say, from being able to do that. We do have, as part of an R01 supporting the AMBL 1531 correlative biology, aim one of that grant was looking at genomic and transcriptomic features that might mediate differential response and toxicity to MIBG therapy. So all of the whole exome sequencing has been completed, all of the germline sequencing has been completed, and all of the RNA-seq has been completed. What we're missing at this point are the clinical data because we're blinded to those, but that will end in October. And then, maybe it's the ATRX patients who are more likely to benefit, which would align with what we've seen clinically, that older patients are more likely to benefit. But so that will be our opportunity to ask some of those questions. When we've looked, like MYC amplification doesn't seem to be a differential biomarker between responders and non-responders. Yeah. Hi, Mel. How are you?
Gastroenterologist, I have to ask this question. I treat a lot of inflammatory bowel disease, and the problem right there is similar. That you have 40% response. You say, oh, that's great. 60% kids aren't responding. So we've looked at biomarkers, and there may be some genes that seem to be associated with better response. But one of the things that's coming out lately is looking at metabolism, microbiome. Is that something that you're exploring?
It's not something that I'm exploring. I have seen more and more oncology trials, including evaluation of the microbiome, but we haven't looked at this. There's a practical issue that the stool becomes radioactive, so there may be some barriers to evaluating that. But you could look at the baseline microbiome as a predictor, but looking at changes in the microbiome, that's going to be tough with radiation safety. Yeah.
So as the other gastroenterologist in the room, I can follow up with that. So in terms of the metabolism of the MIBG, is it taken back up by the gastroenteritis, by the GI tract?
A small amount. Most of it is cleared in the urine, but a small amount is cleared in the stool. Yeah.
And so do you know if it's like glucuronidinated, or is there... Right, there are bugs that metabolize off some of these adjuncts that then free up for reabsorption.
Yeah, I don't know. Yeah. Yeah. Well, the irinotecan for sure. That's well established. That's glucuronidated. Yeah.
Great talk and motivating, very interesting. I had a question about the allosteric data, which is compelling. My understanding that has not been so feasible in clinical setting.
Yeah. Well, it's interesting. I mean, that's been a separate interest of mine, independent of my interest in radiopharmaceuticals. That builds upon work that Clay Gustafson and Bill Weiss have done, looking at the role of aurora kinase in high-risk neuroblastoma. So we've run a number of trials, phase 1, phase 2 combination trials, where we've seen a signal of activity, a relatively narrow therapeutic index with a fair bit of hematologic toxicity. We then ran a trial of a next generation, more selective Aurora A inhibitor that likewise showed a signal of activity. But as a common theme in pediatric cancer drug development, none of those drugs have been a hit in common adult cancers, and they have died. So I don't know with new technology, I don't know actually if anyone is working on an Aurora A degrader or other newer strategies to try to target that, and if we may get a clinical compound that we could actually do an Aurora kinase MIBG combination trial. Yeah, thanks for the question.
Thanks so much.
Yeah, thank you.